So this is really quick. This was really intended to just be a quick food for thought for your lunch, right? So there's not a lot of information, but just to get us thinking about this since it's something that is important part of the newborn screening system. Let me skip. Okay, I'm going to go back to that. In your folders, there are 4 different brochures. Those are the educational materials that we put together in New York. There's one for a baby boy with a mutation, one for a baby boy without a mutation, baby girl with a mutation, and baby girl without a mutation. We ended up making 4 just because of the different information you would want to give a family in each of those scenarios. And rather than kind of have a, if this is your situation, flip to page 2, if this is you, flip to page 3, we just went with 4 different brochures. Of course, if the ALD screening didn't include sequencing, then you may be able to have 1 brochure for everything and not need 4 different brochures. Those are there just for you to peruse, take a look. We're happy to share. I have the Word document file with the text, and if anybody wants, they can use at their will. And we're also happy to take suggestions on those as well. So then long-term follow-up, Dr. Raymond was kind enough when he worked with us on putting together the diagnostic and management guidelines to also have discussions about long-term follow-up. I think the question of missing cases and what's really the outcome of this screening, it may be years before we have some of that information, was on all of our minds from the beginning. So we wanted to put long-term follow-up in place from the very start of screening. So we came up with some different types of data elements, and I also have these in a Excel file in a way that not only gives the data element, but the way that we're collecting it and the type of field that's built into the system. So if anybody's interested in that, let me know. But for the general, which basically means not neuro, endocrine, or family history, we've got how the diagnosis was obtained. So if there was a false negative, it could be entered into this system by the specialty care center. Of course, hopefully they're also calling us because we want to hear about those, but we don't want those to happen. The baby's growth parameters, whether or not they've had symptoms since the last visit, as well as the symptom set number. So there's a structure for ALD where you can assign a number 1 through 8 to describe the baby's level of ALD involvement. For endocrine, we had is the patient being followed by endocrine, is ACTH, all of their testing. You'll see there's some tests that aren't part of our minimum recommendation. We decided that if the endocrinologist chooses to order this testing, it's information that would be useful to collect. So the diagnostic and management guidelines that Sarah went over, we really wanted a minimum set of testing that would be done on every baby, have some equitability so that if they go to any of our centers, they get the same minimum test done. But we know that each endocrinologist may choose to order testing that's different from that, and that's okay, but we wanted to collect that. And then there's a stage of adrenal involvement score of 0 to 3, and that is another sort of easy way for us to capture what's going on with their adrenal involvement. We also wanted to know if they had started therapy or not, and then the age and months that therapy started. For neurology, we wanted to know if they're being followed. Did they have a brain MRI? The date of the MRI. It's also useful to know the way that we set this up is that they get a reminder. A reminder goes out when a year from the child's birth date. So this would be done, they would get this once a year and we'd have updates. We're asking if there was a characteristic pattern of symmetric enhanced T2 signal in the parieto-occipital region. We want the ALD MRI, or now I know to call it the LESS score, their IQ. Were they referred for a transplant and where? Did they have any ADHD? What's their vision? Were they evaluated by a neuropsychologist? And did they have any behavior problems if they were? So this was intended for us to be able to look at how is our screen doing and what are the outcomes for patients that are identified with ALD. We decided not to collect data for other peroxisomal disorders and only for ALD. The family history, we wanted to get some information on that as well, partially for evaluating the impact of the screen. The mother's date of birth we included because we wanted to be able to link families together, and we thought that was a useful way to do that. So if you've got multiple individuals in the same, brothers in the same family, that we could use mom's date of birth to help with linking. We wanted to know whether there was a family history of ALD and what family members, the gender of each family member. An important question is, were additional family members diagnosed after the diagnosis in the proband? So for example, we've had one instance of that where a maternal uncle with Addison disease, who previously, Dr. Parton, correct me if I'm wrong, but was not known to have that due to ALD, was identified because of the screen to be ALD related. The gender of each family member, age of each family member, and if they had clinically symptomatic at the time of diagnosis. So, this was just to start a starting point for this, and I think these things will change over time, and as we start to learn and look at what we're able to use the data for, but this was so that we could hopefully, years from now, go back and answer the question of how we're doing. So with that, that's your food for thought. And if there's any questions, then I'll let you think more about long-term follow-up while you eat. Yes? Yeah.
Who's collecting all that stuff?
Some of this we have IRB approval to collect data, but we're working with getting it actually.
I mean, is the Syracuse, the center in Syracuse supposed to tell you that, or?
Right. Yes.
And it all comes to you then?
Right, yes.
So is that, you mentioned that on the child's birthday, something gets sent out. Is this a questionnaire that goes to the provider or to the genetic counselor at the specialty center, and then they call the family? I'm just wondering about the logistics of how this.
Yeah, so some of this is our plan, and some of it is pending. We have Natus is our electronic provider for our newborn screening software. We also have an online module. So we asked them to build this into our online system, and that has taken some time. It's still in the works. But what it is close to being done, and once it's done, an action in the system will automatically generate for a year after and give them an electronic reminder to complete the form for the following year. Right, so I don't know if everyone, I think a few people here use Neometrics, but when you complete an action, you can set it up to spawn another action. So I set it up so that if you complete the first long-term follow-up form action, it spawns an action that's due a year later. And so that it'll come back on the list as a baby that needs action automatically each year. And then that one spawns one again, and it just keeps going, yeah. So, yeah.
Along those lines, have you decided how long you're going to be triggering these follow-up reports?
Yeah, my brain, I'm trying to remember what our IRB approval says. I think our IRB is up until 27 years. It's coming back to me now because it's been a while. When they're 18, their parents consent, and then when they're 18, they have to re-consent as an adult to stay in the study, and then continue. So our IRB said that we have to remind them every year that they're in the study, and they themselves have to re-consent when they turn 18. Any other? Michelle, did you want to say something?
change providers. So how are you going to track? Are you sending the reminder to the family with a form that says, you know, give this to your provider?
So if they move out of New York, then we're kind of out of luck. But if they move within the state, hopefully, you know, the reminder will go to the provider who's been caring for them, and they'll tell us, this baby's not coming to me anymore, and we'll try and figure out where they're going. So that, yeah, we could have some that end up being lost, you
Because
know.
my understanding is the family is signing consent that they're part of a study,
Right,
right?
right.
So you're not tickling the family with a reminder to say it's time for your annual
Update.
follow-up for the study.
Yeah, the way we have it set up now is that the provider, we have a sheet the provider would give them to say, you know, don't forget you're in the study. If they don't go to that provider anymore, you're right, that's definitely a good consideration. You know, it was a long process to get our IRB approved for this, and a lot of questions from our IRB, and I think, you know, Michelle, correct me if you disagree, but I think part of what worked out is that the newborn screening program was a level removed and the providers were interacting with the family. You know, I think if we add the component of us contacting the family directly, what do you think, Michelle, if
Yeah, that certainly helped, I think, because a lot of people come to us too for studies where they want to do this kind of follow-up on cases, and they want us to, you know, they want a list of all the babies with confirmed blah, blah, blah. And I'm like, we can't give you that information. So by us being sort of the honest broker and then working through the provider, the IRB agreed to do this, to allow us to collect this information. I don't know if, Beth, if you want to elaborate, you know, this ICMS system, we're working on some of the other conditions to do this type of thing. Pompeii was one that we just added, so that's down the line as well.
Yeah, so the online system is, providers can log in, they can view test results, they can put notes into the system with updates, they can fill out diagnosis forms for a few conditions now, and hopefully more as we are able to get our vendor to build them, and then also the long-term follow-up data goes into that system. The IRB went through as a newborn screening patient registry. So there was a little bit of a discussion with our IRB about why are you collecting this data and what's your role? And ultimately we said, we know that the providers in our state and us too want to be able to answer questions about how we're doing. We want to be able to collect that info. For example, the CF Foundation does a fantastic job collecting data, right? And there's really no need for us to collect all the data they're collecting because it's all there. But for other conditions, there's nobody who's providing that role of being the central place for data across the state or across the country to come into. So we decided that, for our state, we would fulfill that need as a place for the data, but that, that's basically, we're functioning in the role of we're providing a place to enter it, and then our providers can come to us with a research question and we can give them back de-identified data across statewide, but it's their data, they're entering it, they're working with us on what data elements we put in,
And another thing is there's a big national effort to do this, and if you're aware of all the different, sort of ways to skin the cat, if you will, there's people want to define cases. We have APHL's New Steps where they're looking at the same sort of thing on a national level of people putting some data about cases so that you get a larger N and can answer some of these questions that came up and come up for every new condition. So there's a lot of efforts, some sponsored by HRSA, some sponsored by NICHD, the national funding agencies to do this nationwide. So we're kind of working with them to set up our statewide so that it's a one-stop and we could go ahead and submit the information whether or not we're federally required. The other thing that's kind of funky in this is the new federal rule of allowing us to report out to parents. So New York State had a law in the book saying that we could only communicate health information to a licensed healthcare provider. So we weren't allowed to contact families really, even for these types of things, or to see how the baby was doing or get our follow-up. Now with this reporting, it's unclear whether we have that sort of, now we have a little bit of a federal push behind us to be able to do that. Because, you know, in the world of newborn screening, we send these letters saying, your baby needs a repeat sample. And we made it a scary letter because we want the repeat. And we get these calls of, why do you need this repeat? And we weren't allowed to tell them. So now we can sort of tell them and, you know, kind of convince them. So it's sort of opening, all these things are happening and opening those lines of communication and allowing us maybe to be more efficient and collect this data. So we'll see where it goes, but we're trying to be a step ahead of the curve sort of and be set up to do this.
Any other questions or comments? All right, well, everybody, thank you so much for coming to the symposium. If you have any questions, and there should be a packet in your folders with contact information for everybody who is here at the meeting. And everybody have a safe trip home and enjoy your lunch.